Hello, today we are doing a case of carcinoma penis patient. Here we can see that the penis, the squamous cell carcinoma of the penis involved the distal end of penis with involved around 4 into 3 centimeter distal part, and we have put a incision, circumferential incision around 2 centimeter away from the distal part of the penis. We have actually injected lignocaine. We have identified the dorsal artery of dorsal vein of penis. Then now we are ligating the corpus cavernosa. Here the corpus cavernosa is being dissected, and the corpus spongiosum we had identified and preserved. So we are cauterizing the corpus cavernosa now. So here we can see the corpus spongiosa that was preserved for this patient. So we have completely separated the corpus cavernosa now, and this part will be sent for histopathological examination for margins. Now we are cutting the corpus spongiosa around 2 centimeter proximal to the part where we have divided the corpus spongiosa. We are separating all the other structures. Now we are cutting the corpus spongiosa. Through this we will be putting the the catheter, and this will drain the bladder. So now the distal part of penis is completely separated. We have released the penile clamps with infant feeding tubes, and now we will suture the corpus spongiosa to control bleeding, followed by we have spatulated the urethra here and sutured the urethra to the skin to prevent urethral stricture, and this catheter will remain there for 3 weeks. Following that, we are doing a bilateral inguinal lymph node dissection, as this patient had superficial inguinal lymph nodes palpable. Here on the right side we have completed the inguinal lymph node dissection. Here we can see all the boundaries. Superiorly we can see the inguinal ligament here. We can see the spermatic cord superiorly, which is retracted now. All the superficial inguinal lymph nodes were cleared. So one anomaly we found in this patient was there was a complete absence of great Sphenous vein. Here we are trying to demonstrate the this is the femoral artery, lateral is the femoral vein, and we can see here the great Sphenous vein is absent for this patient, which was aplastic. We can see superiorly that great Sphenous vein had become aplastic, and we have ligated all the lymph nodes on the right side. Following this, we have put a drain and closed the right side and proceeded with the left side inguinal lymph node dissection. Here we can see the picture of inguinal lymph node dissection with superior part on your left side of the screen. Here we can see the psoas major, the inguinal ligament, the adductor brevis there, this is the adductor longus, this is the sartorius forming the lateral boundary. Here we can see the femoral artery, the pulsations can be seen clearly. Following that, you have seen the great Sphenous vein, the femoral vein, and we have done the flush ligation of the great Sphenous vein at the sphenofemoral junction. That is the proximal part, and this is the distal part. So we have cleared the left inguinal lymph.